can we have Dr. Jyoti Matalia? Yeah. For her presentation on acquired nystagmus, evaluation and principles of management.
Yeah, so good morning, and I'm going to be talking primarily on acquired nystagmus and try to decode and how you should go about. So what is nystagmus? It's an involuntary rhythmic oscillations of the eye which have a fast component and a slow component. So you can see here the slow component is to the right and the fast to the left, and it is a fast component that helps us detect the direction of nystagmus. So let me take you through the classification. So basically this is physiological and non-physiological, but what I am going to talk to you is about acquired versus the congenital one. So how do you differentiate? So importantly, note the features. So you have you understand that acquired is purely sinusoidal. It's asymmetric compared to the congenital. Direction is omnidirectional, vertical, circular, elliptical, but in case of congenital it's horizontal, uniplanar, and rarely you get vertical or torsional. Remember, the OK and reversion is never in the acquired compared to that in congenital. And oscillopsia, where the patient believes that he is able to see the images moving, is frequent in cases of acquired. Now this is a very good classification. Those who want to know can look at this, the CMAS classification, for trying to find out the various nystagmus types. So I'm going to simplify the various types of acquired nystagmus into jerk and pendular, basically on the morphology. So let's look at the jerk, and I'll try to describe in terms of the vestibular peripheral and the vestibular central. So how do we go about? So vestibular, you can see, is unidirectional or multidirectional as the central cause, whereas the peripheral one is unidirectional towards the normal eye. You also look for the central and the peripheral signs related to the brainstem, and the other peripheral is related to the ear. And you should understand the central gets suppressed with visual function, visual fixation, but the peripheral does not get suppressed. And the specific signs that the brainstem or cerebral will be seen in the central, and the vertigo, hearing loss and tinnitus will be seen in the peripheral part. So let's try to differentiate these 6 etiologies and the 6 types of central vestibular nystagmus. So let's look at the downbeat and upbeat. So the upward drift followed by a corrective downward saccade is a downbeat nystagmus. Classically features at pontomedullary junction, and flocculus is the site. You should know the causes are Arnold-Chiari malformation, very common, where the cerebellar tonsils they slip down, and these are the various causes that come for downbeat nystagmus. Commonly MS and drugs is what you should have, so good history. This is a child who had a downbeat nystagmus. So you can see the eyes which are moving downwards. Now upbeat, on the other hand, has a fast phase beating in the upwards direction. Side being superior cerebellar peduncle and the pontomedullary or the pontomesencephalic junction. Again, these are the various causes, and you'll get the details in whenever you look in the Google and all. Now this is a classical child who had upbeat nystagmus, but what you should understand in a child, the history of consanguinity, don't always jump to neurological. It's not always neurological. So we have found out a case of upbeat nystagmus with a cone dysfunction. So important history of consanguinity, and in a child eventually this upbeat becomes a horizontal. So try to study your nystagmus in children over time because it can change. Then is the seesaw or the hemi-seesaw. So intorsion and elevation of one eye and simultaneous extorsion and depression of the other eye is a classical seesaw, and this is the site where you normally see it. Important is paracellular tumors, so pituitary adenoma, craniopharyngioma is what you should look for. And infarcts or hemorrhages, trauma, congenital causes is what you should rule out. So this patient classically had a paracellular tumor and her classical seesaw nystagmus, as you can see. Then the periodic alternating nystagmus, horizontal nystagmus that predictably oscillates in direction, amplitude and frequency. So look at the nystagmus for 3 to 5 minutes. So you can see a right beating nystagmus. Eventually, if you keep on concentrating, becomes a left beating nystagmus. So this is very important. So watch the nystagmus. Don't jump to conclusion on the basis of just one looking at. 5 minutes is required. And these are the various causes, what you can see. And so in this patient, a left beating nystagmus, after some time you watch him, it goes into right beating. So this is how you pick up a periodic alternating nystagmus. A convergence retraction nystagmus is classically a nystagmus which is a part of the dorsal midbrain syndrome with an upgaze palsy, defective conversions, eyelid retraction and light near dissociation. So you can notice he's trying to converge, he cannot lift his eye upwards, and there's some amount of retraction which is there. But if you see the horizontal movements are perfectly okay, there is no issues, but he's not able to converge or he's not able to lift the eyes up. So this is the classical feature. See, you try seeing the eyes are retracting when we are making him attempt to look up because he cannot look up. Side being posterior commissure lesion, and these are the various causes of a convergence retraction nystagmus. And finally, the internuclear ophthalmoplegia. This is a dissociate disconjugate nystagmus with an eccentric gaze nystagmus, where you see that the left eye is not adducting, but the right eye has an abduction nystagmus. and the causes being brainstem infarct or MS. And this is what you can see a patient had it. So what is a quick summary for these kind of things when you have an abnormal eye movement and the possible lesion? So it's a dissociated nystagmus or INO, it's the MLF, medial longitudinal fasciculus. A downbeat nystagmus is cervicomedullary junction. Upbeat nystagmus is a posterior fossa. Seesaw nystagmus is paracellar. Monocular nystagmus of childhood is anterior visual pathway. Periodic alternating nystagmus is a posterior fossa, and convergence retraction nystagmus or a dorsal midbrain. So now let's quickly look through the pendular causes of acquired nystagmus. These are the various. Pendular is a sinusoidal movement. You don't have a fast component here, but somewhere the eyes are moving sinusoidally. These are the various etiology. Classically, the spasmus nutans, which is a triad of head turn, head nodding, and you can see the simmering reflex which is there, and it's in a child, which typically develops the first year of life and resolves by the 10 years, and you have to rule out a CNS glioma. Then you have the OPN or the oculopalatal myoclonus, which is a acquired nystagmus of contiguous and rhythmic movements of the soft palate, and therefore you should ask the patient to look at the palate. You can see the palate moving along with a vertical pendular nystagmus, and it occurs after injuries of the brainstem or the cerebellar regions. Then the OMM or the oculomasticatory myorrhythmia. Here you can see it's a conversion diversion nystagmus. That means a disjunctive nystagmus, also called as PVOs, pendular versions, oscillations moving in opposite direction, are very, very pathognomic of Whipple syndrome. So when you have conditions like this, and the rest, as you said, acute brainstem strokes, you have central myelin, multiple sclerosis, so you need to take the history and find out what could be the cause to it. So when you have something like this, there are multiple treatment options, but always try to do it along with your neurologist, and it's all best. I have the advantage of being in a health city where I get a direct coordination with the neurologist, and you can plan the treatment. But ending by saying that if you need sometimes surgically also it's important, where you do large for muscle recessions of about 10 to 12 millimeters of the horizontal recti, so as to relieve them if you're not able to completely correct them by medications. And by ending that there are certain serious neurological diseases you should think when you see an asymmetric nystagmus, a monocular nystagmus, which is a visual pathway disorder, vertical nystagmus, and a purely torsional nystagmus, provided you have ruled out a congenital cause. So thank you very much for a patient.
Is there any difference between the head posture? You have not mentioned that.
Yeah, so these are acquired cases. So when you are talking about head posture, we're looking at specific congenital ones, which are there since birth. In acquired, when they come later, they are ortholopsia, and whichever direction they look, they would not have a specific head posture.
Nice presentation. It's really important for us to focus on the type of nystagmus in order to locate the point where the problem is. And in acquired, most of the causes is, I think, trauma and any drug induced.
Yes, very common. So basically important in any neuroophthalmology is take history. You have to take very important. Sometimes it's difficult to even pick up that particular nystagmus, so take your videos, sit back, call the patient again, sit and study the nystagmus. You can study over time, so always take video photographs of them, and over time you'll understand that yes, this is what it is, I thought it was different. So take videos, take history, sit and think back. You can have a group and talk to them so that you really know what you're looking at, and always have a good collaboration with your neurologist so you know what you're thinking, what they are thinking, and then it helps us to build it up. Yeah, sure. Yes, acquired nystagmus definitely, yes. But that's what I'm telling you, need to really differentiate. Many a times a patient comes, he's not aware that there is nystagmus, and then you look at his old videos, then you remember that he's been having a head posture, there is something there, and it's not entirely congenital. But in doubt, always do it. It's always best to be there.
Yeah, so I think most of us develop the seesaw nystagmus on seeing a patient of nystagmus, but your very nice presentation and particularly the inclusion of very good videos, I think that would make that less evident.
Yeah, so we actually did these animations to make people understand, because in clinical it's difficult, but when you actually show it, then you know what you have to compare with. So that is.
So these were really nice. Yeah.
Okay.
Thank you for
the
the
thank you.
presentation.